work. Don't do tourniquets half-assed. Make sure you put on a tourniquet that's approved. Make sure you know how to operate the tourniquet that you're going to put on. You should know how to operate all of your own gear plus the gear that your buddy's wearing. But know how to put it on, know how to work through it. Because, again, much like firemen, if you can't tie a knot, tie a lot. Tourniquets don't work either that way. Hemostatic or compression dressing indications, these are going to be junctional wounds. Think buttocks, sort of, up in the axilla, the groin, maybe somewhere in the neck. These are going to be areas that you can't put a tourniquet on. But again, we're looking at uncontrolled bleeding from the wound, bandages and direct pressure ineffective, or again, the same thing, where prior bleeding, now the patient is in shock or it has some type of altered mentation. The take-homes when it comes to wound packing, you need to take, when you're getting ready to pack it, a bunch of the gauze and wrap it up in a little ball and jam that ball deep down inside and push that against the bone. The reality is that sort of ball that you set in there is what's going to create all the pressure that we're going to push down into the wound to stop it. It is a pretty disgusting feeling, putting your finger into somebody's leg, arm, chest, whatever. You'll probably require therapy for a whole nother round of issues. I wouldn't worry about that. But again, if this is the type of thing that bothers you, if this is something that puts you over the top, know your limitations. But be ready to coach somebody on how to do this. If you can't do it, make sure you can explain to your buddy behind you how he can. But the big things with this is you're going to expose the wound, you're going to make a ball, push it down, pack it tight. Get it as full as possible, and then 3 minutes of pressure on the top to let that hemostatic agent begin to work. The key points with this, multiple hemostatic dressings may be required to stem bleeding. This does not mean you put them in, wait 3 minutes, pull them out, put new ones in. Do not do that. Multiple hemostatic dressings may mean you put 3 dressings inside of somebody. There are going to be holes, especially when we get up to high energy weapons and you're dealing with rifle rounds. They create big freaking holes. Handgun rounds, 7 yards, I guess is the Z-pack. 1 pack is usually enough. But once you get up to rifle rounds, you actually have big holes that you're filling. You may need multiple packs to get it. Failure to make that initial packing with that ball deep and tight will never allow the dressing to work. So again, I'm going to go back and say, if you don't do it right the first time, there's no sense doing it. Because what we'll have at that point is, we'll have this huge caked dressing that blood is pushing up against and pushing out, but never providing the pressure down on the active bleeding site. So make sure, again, you set that well and you set that tight as you go in. Hold pressure for 3 minutes. Compression dressings can be effective in creating direct pressure over a wound. So again, when we're talking about the Israeli dressings and the EDT and some things like that, they may be good at wounds that don't have active bleeding, but really, when it comes to hemostatic agents, using them in conjunction is something that sometimes works. Pack the wound and then put a compression dressing over top of it. While you're holding your pressure for 3 minutes, make it tight, and then send them out. Remember the picture of the guy who stepped on the IED, missing half of his leg? We teach junctional pressure points with the hope that we will be able to stem some type of bleeding in those cases. If I have a transection that's very high, my best hope is that maybe I can stop the blood right up where it's coming out of the pelvis. Specifically the femoral artery as it passes through the pelvic canal. I will tell you right now, we spend a lot of time teaching it, but it is almost impossible to completely stop the outflow. They did a cool study on this where they actually used different techniques. We have some tools available to us, but they did a neat study actually with Doppler to see how much flow lasted. In some of the commercial devices, and these things are crazy, they're like erector sets. Like you gotta put all this crap together, and I'm thinking about trying to put it together while I'm getting shot at. It's never gonna happen. But the knee in the groin on top of the femoral artery is what most people get taught.
I just went to the Army Cls class last summer again, and they actually had that tourniquet that goes around the waist. I guess, is that one of the tools that you're talking about?
It's one of the tools. They also have one, is that the one that's got the 2 bladders that you fill up?
Yes.
So it's got pressure points right here, and the goal of that is to push enough pressure on both of the femoral arteries to reduce the outflow. The problem is, even in those cases, they can only reduce about 85% of the outflow, which means there's still going to be some bleeding. So the big thing, again, the takeaway with this is, can you partially compress it? Yes. Can the tools partially compress it? Yes. Are they going to provide you with a lasting solution? Probably not. This is going to be somebody that's going to need to get moved up and expedited when it comes to getting them evacuated. Airway management. The big things for this are altered mental status with an inability to clear their own secretions. Things that look horrible like this, if the patient is conscious and alert, can be managed without you monkeying in their wounds. Right? Hear me when I say that. This guy, if he can lean forward and clear his own secretions, he doesn't need either me or Colin dropping an endotracheal tube in him or anybody putting an NPA in. If he can clear his own, he's okay. The caution I will give you is, because he is okay this minute, does not mean in 2 minutes he's going to continue to be okay. But while they can control and sort of protect their own airway, allow them to do so. The other indication is when you have significant facial trauma where structural degradation and damage prevents normal airway function. These are really sort of more common when you have massive blunt trauma to the face, and you end up doing fractures of the mid-face and all the way down. It ends up collapsing a lot of the structures that we rely on to be open. Those will require some type of airway management. Those are most likely going to require airway management outside of your comfort level. It'll be, again, probably most likely a surgical percuthotomy. For the unconscious casualty without an airway obstruction, place in the recovery position, do a chin lift or jaw thrust maneuver. Again, this is super easy. Like you can see when their head is balanced, how much you have an obstruction right here. Bringing their head back opens that and allows things to move. You can place a nasopharyngeal airway. Again, Colin's going to go over some of that with you. If you have someone with an impending airway obstruction, again, the guy who ended up blowing off half of his face, if he's able to protect his airway now but may not do it further, again, make sure that they're in a position that's going to best do it. Watch them carefully, consider how you move them, and consider, again, a nasopharyngeal airway if they're unable to control any of their own airway. Airway management procedures, the nasopharyngeal airway, the nose hose, trumpet, whatever you want to call it. It is a super easy tool that you should have in your IFAC that is great for providing some type of basic awareness or basic sort of protection for your patients. Tolerated well in conscious patients, inserted at a 90-degree angle to the face. I hate when I see EMT students come out and they try to push it up like this. That is not the direction that your airways go. It goes straight back in. So perpendicular to the face, push it right back in. Colin will cover that with you guys. Secure it with tape. Do not use an oropharyngeal airway. Those are the hard plastic ones. If you have a semi-conscious patient, they're going to start vomiting, they're going to aspirate their vomit, and then you have 10 times the problems that you had before. Oropharyngeal airways are only for unconscious patients. You guys are going to be dealing with patients at a varying level of consciousness, so stick with the NPA. This is just a quick video that shows sort of how to do it. Again, you're going to lube it up. They say measure it. What we end up doing is we end up saying that a 28 French is about the average size for everybody. Could somebody take a 32? Yes. Maybe even a 36, but the reality is 28 is the smallest size that fits most people. And it's easier to put a smaller one in a large person than a large one in a small person. Straight back in and down, and that's all there is to it. And Colin said he would do it for you guys. Advanced management that you will see from a combat medic or a combat lifesaver may involve things like a supraglottic airway. You know, when we're in the street doing airway management, we do a lot of endotracheal intubation where we stick a laryngoscope in their mouth, we lift up, we push it down, we actually pass the tube all the way down past their vocal cords. That is a very difficult skill. Medics practice that literally for careers and sometimes don't ever get perfect at it. The nice thing about supraglottic airways is they're blind insertions. And it's a device that you can literally grab somebody by their jaw, pull it out, stick this thing in blind, and begin ventilating them by it. It's another tool that you're able to use. The caution that I will give with these guys is these can be dislodged very easily during movement. It's one of the reasons why I hate using them in the street. If somebody's on a backboard and they're secured and I know that they're not going to move, that's great. But how many times have you seen somebody drag a patient, whether onto a stretcher, off a stretcher, down the stairs, wherever, their head's bouncing and moving? These things will get displaced pretty easily if you have an excessive amount of movement of the head. So just be aware of that. But again, it's a good tool that can be used. Very high success rate. The failure rate with it is extremely low. It is not the end all. So if there is any damage to the structures of the face, again, if we're talking about penetrating trauma to the face, you may not ever get this to seal appropriately. In those cases where you cannot make that airway work, combat medical considers something like a surgical cricothyrotomy. This is a terrifying type thing. Sticking a needle in somebody's chest is one thing. The thought of taking a scalpel and cutting their neck open to breathe for them should terrify you. I'll be honest with you, I've been a medic for almost 25 years. The thought of doing that terrifies me. And I've done it once. This is the type of thing, again, that is an incredibly invasive procedure. And one of the biggest things about this is it has a very high failure rate, even when we look at some of our highly specialized military medics, whether it be the corpsmen, PJs, whatever. They have a 33% failure rate for this skill. That sucks. Because again, it is a very difficult skill to perform. What happens is we line up the head, we make a vertical incision, we open it up to expose the trachea, we cut a hole straight down into the trachea, and then we pass a tube into the trachea to be able to do that. When this happens, this patient needs to be out of your hands in a heartbeat. Like, you guys need to be planning for whether you got a helicopter on the way or somebody else to make them not your problem, because the ability to manage them moving forward is going to get increasingly difficult. So this is them trying to put in, you can see how they cut a hole. They're going to cut a hole right in the middle of the neck. Finger in to sort of, so you don't miss your place or lose the hole that you created, because everything will close back over when you move your finger. Finger goes all the way in, down into the trachea. Sometimes they have to open it up more. So they'll use hemostats or some type of agent to sort of spread it and pull it open, and then they're going to take a tube and feed it straight down inside. Just like you'd see somebody with an ET tube that was put in by a medic, except rather than going in their mouth, it's going in their neck. One thing that nobody ever tells you when that stuff happens, it is incredibly bloody. It is a very high stress situation. Medics don't want to be forced to do that. But when you have patients with complex airway issues that you cannot manage with basic maneuvers or with a supraglottic maneuver, that's probably one of the few options that you have left. R in March is respirations. This is where we're talking about chest seal and ventilations. Penetrating chest wounds. The ones that you have, open chest wound caused by high energy projectiles, bullets, shrapnel, whatever. Open chest wound caused by low energy projectiles, possibly even an etched weapon. This is not indicated for blunt trauma or closed trauma to the chest. Okay, so if somebody ends up taking, we use kinetic impact rounds pretty frequently in our world. If they're having trouble after being shot in the chest, they do not need a chest seal. They actually probably need to be decompressed because they're having a tension pneumothorax. These are going to be an important tool for you guys, again, to be able to use and to be able to use quickly and effectively. The sooner you get a chest seal on an open wound, the better our chances of being able to control the outcome of it down the road. Remove any armor. The big thing with this is you've got to clear the area to be able to see it. So whether you're pulling them out of their kit, you're tearing off the uniform, whatever it is, you need to be able to expose it. You need to wipe it clean because you're about to put something incredibly sticky on. And if there's a ton of blood on the surface, it will never adhere. Get it in place, adhesive side down, push it down, seal it well over the wound. If there is any trouble breathing, you can pull up a corner. Most of them, Hyphen has it. Almost all of them have it. There's usually a big tab on one side that you can actually pick up without it sticking your fingers. We do what's called burping the dressing. What's happening is air is beginning to build up now in that space, and it is causing the lung to compress. We need ultimately to be able to stick a needle in to decompress them. But if you don't have that option, you can pull up a side of that dressing. It'll begin to let a little bit of air out and then seal it back up. It's something that requires management, depending on how critical they are, anywhere from every 30 seconds to a minute to every 5-10 minutes. But again, just be watching. If you put a chest seal on somebody and they're starting to have increased difficulty breathing, there's air that's building up in spaces that it's not supposed to be. Consider just pulling up a corner and letting that burp to let the air out. If you have entry and exit wounds, put one on both sides. Do you know what's in your kit? Do you carry 2 chest seals in your IFAC? It's probably an important thing to realize because, again, most of what we see, especially in the street now, is we're seeing a lot of high-power weapons. Heck, you get up into northern Montgomery County and all the deer hunters have all their 308s. It's going in the front and it's going out the back. You're going to need a chest seal on both sides. The combat medic is going to probably look at this as an opportunity to do decompression. We talked about this briefly as tools. This is when you're taking a 3-inch needle. There's 2 different sites that you can do it from. Colin does not like the way that I do it. He likes to do it in the axilla. I prefer to do it over the right over the anterior chest. A lot of times when I'm looking at the patient and I'm assessing the patient, that's where I have access. But you're going in the 3rd intercostal space, which means you find the clavicle. The first rib is pretty much underneath that. You come down 1. And then the space right below that second one is the sort of the space that you're looking for. You're going to go right over the top of the 3rd rib, and you push that entire needle all the way in. It feels kind of terrifying to do something like that, but again, that's going to be the gold standard for managing a tension pneumothorax. We've been doing it in the street forever. Advanced trauma life support, which is what they teach emergency room physicians and trauma surgeons, they teach this as the initial intervention for a tension pneumothorax. Physicians, this is what they teach to do because it is the fastest way to decompress sort of that expanding area in the chest. Now, a physician is going to follow this up with a chest tube that's going to go on suction and allow a bunch of other things. But this, again, is somebody who needs to beat feet and get out as quick as possible. The other thing with circulation is pelvic injury. Sorry. And it's going to be loud. 26% of soldiers who died in Enduring Freedom and Iraqi Freedom had a pelvic fracture. I say that from the standpoint of it's important to understand that 1/4 of the fatalities had an associated pelvic injury. It happens frequently. The problem is there is absolutely nothing you are going to be able to do to really stem the hemorrhage from a pelvis. We talk about using pelvic binders, and it's a tinker toy thing that we're pulling tight, and it's pulling the pelvis together, so in case of a fracture, it minimizes sort of the sharp edges doing more damage to the vasculature. It helps a little, but it doesn't fix it. Not the medic, nor the Army physician can fix this. They need to be in a trauma center. They need to be somewhere where somebody can open them up and start moving through with a vascular surgeon to put things back together. So pelvic injuries, again, they have an incredibly high mortality rate associated with them. I had a guy over the weekend, redneck farmer out in Lancaster, Chester County. Big old tractor roll over on him, pinned him by his pelvis, crushed his pelvis, broke his femur. It's the type of thing that, again, shy of him being in a lot of pain because it hurt. I mean, we medicated the living crap out of him. I don't even think he remembered that day happened. But the problem is there's such a high mortality associated with that because of all the damage that happens to the vasculature around that area. You can bleed out from a fractured femur. You can bleed out from a fractured pelvis. Those types of things, again, require a very high sort of level of awareness and a recognition that we need to do something about getting them moved. The big thing is try not to move them more than you have to. Circulation, reassess for bleeding all the time. Make sure your tourniquets are sound. If you got somebody who's got a changing condition, they're starting to become a little bit more altered, check your tourniquets, check your wound packing, make sure there's nothing new. As far as being able to do things when it comes to a pelvic fracture, again, sometimes we'll use a pelvic binder, but the big thing, again, that a combat medic will probably end up doing is starting TXA and IV fluid resuscitation. TXA is a great drug that we've been using now for probably about 8 or 9 years, which is great at helping the clotting cascade start sort of from the inside. So we use clotting agents and Clox and Quick Clot to sort of start from the outside. We're able to give drugs like TXA, tranexamic acid, to be able to start the clotting process on the inside. The last one is head injury and hypothermia. I'm not going to focus too much on head injury because the big thing about a head injury is there's not a lot you're going to be able to do to fix it. Hypothermia, on the other hand, you have a profound ability to affect how that works. The big thing about hypothermia is it is much easier to prevent than it is to treat. What we see in shock, as soon as people become hypothermic, the incidence and increased mortality freaking goes through the roof. If you have a casualty that is somehow compromised in any way, shape, or form. Please keep them warm, keep them covered, do not allow them to get hypothermic. In a 70-degree ambulance, can you be hypothermic? Absolutely, especially when you're sweating, especially when you're hypovolemic and you don't have quite the ability to move the blood that you need, you can get hypothermic quickly. Remove all the wet clothes. Be aware, again, when it comes to hypothermia, it affects your body's ability to clot. So if you have somebody who's bleeding, whether it be internally or externally, if they're hypothermic, their body's natural clotting mechanisms are not going to work as well. TAC-evac, we're not going to spend a whole lot of time on this. The whole goal of this is to make them not your problem. Make them my problem. The big things though, especially as you're getting rid of these patients, we need to be able to understand what's wrong and what we can do to sort of affect a change or a help to get them sort of where they are. So provide as much security as possible, whether they're going to an ambulance, a helicopter, whether they're being put in a Bearcat, moved out, it doesn't really matter. Try to provide as much as you can, get them out to advanced level care. This seems to frustrate a lot of people, but I'm just going to be completely blunt with you guys. When it comes to CPR and battlefield resuscitation, it is a complete waste of time. There was a study done on the civilian side. 12,462 traumatic cases were evaluated. 138 of them went into cardiac arrest, and resuscitation was started on them. Not a single one lived. I don't want to be the one that says, we're just going to give up. But the reality is, when you're in cardiac arrest, you are dead. And if you are in cardiac arrest on the battlefield, in a tactical environment, or in any other space that is hostile, your ability to change that situation is grim at best. Cost of CPR in a tactical environment. CPR performers may be killed. Again, you're putting yourself in a dangerous position. The mission will be delayed, and the casualty stays dead. There's plenty of stuff that's showing that now. The exception that I will say to you when it comes to cardiac arrest in an austere environment that may be worthy of additional consideration: hypothermia, near drowning, electrocution, or other non-traumatic cases. There are a few, but none that are really worth really focusing on. Again, in our applications, when it comes to trauma and a trauma arrest, don't waste your resources and your time trying to do CPR on somebody who's dead. They're not going to get undead. You could get dead, and everything's going to get delayed. So just think through that when you see that. That was record time. Any questions on this stuff? You guys are going to have time to talk to everybody else. What do you got?
Is a pelvic fracture considered like a C-spine injury?
No,
Like,
that's actually a great question, because technically the bottom part of the pelvis is all fused vertebrae, but we don't treat that like a spinal injury because the spine stops right above where the pelvis is. The spinal cord stops right above where the pelvis is. Great question. Any other questions?
A perfect example of a pelvic injury, like in John's case, we were talking about his shattered pelvis call, or like they did out in Chester County. That's a patient where we don't ever really put that person on the backboard because it's going to do more harm than good. This was a case where the patient was on what's called a scoop stretcher, where it's actually the whole line on your back where your spine would be is completely empty. So you basically scoop them up and unscoop them. A fractured pelvis will cause more damage to your vasculature as you move them. So something to keep in mind.
What other questions you guys have? Sorry that was so fast. Let's take 5 minutes. Take a break.